For patients with microsatellite unstable colorectal cancer, we have seen benefits of immunotherapy for these patients. We do have multiple FDA approvals for these patients of agents including pembrolizumab, nivolumab, and now nivolumab plus ipilimumab. We see single-agent response rates in the range of 30 to 50% for patients with PD-1 inhibitors, and we also know that patients who respond to these PD-1 inhibitors tend to have very prolonged responses. The CheckMate 142 study looked both at single-agent nivolumab and nivolumab plus ipilimumab. The two arms weren't meant to be compared to each other, they just enrolled side by side. Very interesting, the Nivo plus Ipi data showed a response rate of about 55% and showed a 1-year overall survival percentage of over 85%, which is very significant for patients with advanced colorectal cancer and probably the basis of now Nivo Ipi being approved for this subset of patients. We do see toxicities with immunotherapies. The combination of Nivo plus Ipi for patients with colorectal cancer is a dosing of Nivo 3 Ipi 1, and you only receive the ipilimumab for a certain prescribed period of time. We do see some increased toxicities with the combination as compared to the single agent, mostly noted in terms of colitis. We are educating our patients and educating other physicians about potential toxicities from immunotherapy, which can include thyroiditis that then leads into hypothyroidism. We have diarrhea and colitis, we have pneumonitis, hepatitis, and all different kinds of autoimmune type effects that we see. So we definitely have to monitor patients. We monitor their thyroid carefully. We look for rashes. We tell people to let us know if they have any more shortness of breath or if they're having diarrhea. We monitor their liver function tests. And there are other less common itises or autoimmune effects that we see, like myocarditis and hypophysitis. So we always just have to keep those in mind if our patients on immune therapy are having any type of toxicity. Typically, these are treated with stopping the immunotherapy and then starting steroids, usually 1 mg per kg of prednisone or 2 mg per kg of prednisone with slow tapers, and then monitoring these patients very carefully for resolution.
Recently, the FDA has approved nivolumab plus ipilimumab for patients with MSI-high colorectal cancer. My big problem with this study is that it really hasn't randomized patients with nivolumab plus ipilimumab versus nivolumab. So when I look at this study, I really can't tell which patients really need the 2 drugs versus the 1 drug. Now, this is why it's important. When you have the 2-drug combination, you end up adding significant toxicities and significant cost. But I'm not sure that you're adding superior efficacy because they've never been compared. So it makes it very difficult to really understand how to position this dual inhibitor regimen, dual checkpoint blockade. And the same applies if you want to compare it historically to pembrolizumab. Now, that's only applicable to colorectal cancer. MSI-high tumors outside colorectal cancer only have 1 indication, that's pembrolizumab. But for colorectal cancer, now we have nivolumab, pembrolizumab, and ipilimumab plus nivolumab. From my standpoint, any patient with MSI-high tumor right now, I would treat them with nivolumab or pembrolizumab. I would not go for the dual inhibitor. The dual inhibitor will only come to play in those patients who may have a response initially and then escape that response. And I may try then the doublet, the dual inhibitor in those patients. I don't feel compelled right now to use the 2 drugs instead of the 1 drug. And primarily because, again, the cost, toxicity, and lack of comparative efficacy, superior efficacy. So we don't know that. To expose my patients to the effects of the 2, I have to have a study that tells me it's better than 1. And historically, it seems maybe a little bit better, but impossible to say without comparing the 2. So standard in clinic, PD-1, so Nivo or pembrolizumab, and then for those patients who fail after initial response. So we'll talk about the non-responders. So fail after initial response, those patients would become eligible for the 2. For those who fail immediately, those are unlikely to respond to immune therapy, dual or not. And those patients probably would go a different path. Could be another immune therapy studies that we have on hand or back to chemotherapy.